My name is Erica Richards, and I will be presenting along with McKenna Andrew, Anna Kate Bowman, and Avery Hughesby on the need for change in healthcare worker PPE compliance. As we began working on this project, we all discussed situations in which we ourselves observed the inadequate or inappropriate use of PPE by healthcare workers. These are some of the scenarios we witnessed during some of our clinical shifts. The below examples include: Example 1, a nurse and a student went into a contact precautions room and the nurse did not wipe off their stethoscope before seeing the next patient. Example 2 includes: a nurse and a student were caring for a patient on droplet precautions and wore masks themselves, but did not mask the patient. Example 3 includes: a student observed a PCT enter a room without gelling in. Defining the problem. Healthcare settings have an increased chance of spreading germs compared to other workplaces. This will largely be due to the regular exposure of a large variety of organisms and substances, as well as direct patient care that often involves very close contact with others. Healthcare-associated infections, otherwise known as HAIs, continue to impact patient mortality and can be prevented by proper isolation precautions being taken. Nurses, for the most part, are aware of the seriousness of infection control, but some continue to remain lax in the standards and recommendations set by facilities and institutions. One literature review of 32 studies in the U.S. found that nurse PPE compliance was only at 34%. Another small study in the U.S. found that only 24% of nursing participants properly were donning and doffing PPE. Isolation Precaution Overview. For the purposes of our presentation, the following definitions of isolation precautions were retrieved from a peer-reviewed article from the National Library of Medicine. Additionally, the Centers of Disease Control and Prevention set the standard for isolation precautions. However, isolation precaution guidelines may vary by facility. Firstly, we have standard precautions. For all patient care, protect healthcare providers from infection and prevent the spread of infection from patient to patient. Examples of this would include hand hygiene, the use of gloves, and safe injection practices. Next, we have contact precautions. Patients with known or suspected infections that represent an increased risk for contact transmission. Examples of this may include performing hand hygiene before and after patient care, and donning gown and gloves prior to entering the patient room and performing patient care. Droplet precautions. Patients known or suspected to be infected with pathogens transmitted by respiratory droplets that are generated by a patient who is coughing, sneezing, or talking. Examples of droplet precautions include donning a mask and eye protection prior to entering a patient room. For airborne precautions, we have patients known or suspected to be infected with pathogens transmitted by airborne routes. This might include TB, measles, and chickenpox. An example of airborne precautions include donning a fit-tested respirator, such as an N95 mask, prior to entering a patient's room, and also ensuring that the door to a patient room remains closed.
As you can see here, these are the potential signs that might be outside a patient's room, indicating what kind of precaution they are on. These signs are to remind staff and visitors of what needs to be done before entering the patient's room and when leaving the patient's room. Again, these signs may vary depending on facility protocols. Our group has decided to implement the Lewis three-step model to propose our change. This theory is a common change theory used by nurses across specialty areas for various quality improvement projects to transform care at the bedside. This model consists of the following 3 steps. Number 1 is unfreeze. Things that happen under the unfreeze step include recognizing the need for change, determining what needs to change, encouraging the replacement of old behaviors and attitudes, ensure there is a strong support from management, and manage and understand the doubts and concerns. Number 2 is making the change. Things that happen under the change step include planning the changes, implementing the changes, and helping employees learn new concepts or points of view. And number 3, refreeze. Things that happen under the refreeze step include changes are reinforced and stabilized, integrate the changes into the normal way of doing things, developing ways to sustain the change, and celebrating the successes of the change. The first step in this theory is unfreeze, recognizing the problem and preparing for change. We have planned for this step to take approximately 1 month to complete before moving on to step number 2. We recognize the need for education on personal protective equipment knowledge and compliance due to our own experiences, as well as the literature suggesting the need for better PPE adherence. More times than not, we have all seen a staff member or a family member walking in or walking out of a patient's room without following what the precaution sign says. What's that famous saying? Monkey see, monkey do, right? After getting management support, we would plan to assess baseline knowledge about PPE understanding and compliance by creating a questionnaire. This questionnaire will be taken by staff members in order to determine what needs to change. We will also ensure staff members can properly apply PPE by having them demonstrate their knowledge. The goal in this step is to encourage replacement of old behaviors of PPE compliance with new ones that will positively impact patient outcomes.
The second step of Lewin's change model includes planning the change, implementation of a new plan, and teaching of the new concept. This is known as the change step in the model. For our purposes, the group found that there was a need to determine where gaps in noncompliance lie. This can be done by statistical analysis and/or surveys among the staff members on any particular unit in question. Secondly, we are proposing construction of learning modules, demonstrations, and seminars in an attempt to address proper PPE adherence. Making these modules a mandatory education course could prove to be beneficial in eliminating noncompliance for proper PPE use. The third and final step of Lewin's change model is deemed the refreeze stage. This step includes the embrace of new change and monitoring its effect on the work environment. 2 areas we would expect to explore include the reassessment of nursing knowledge and demonstration of proper PPE use, as well as the enforcement of evidence-based practices, including appropriate PPE techniques. Ways to assess the effectiveness of these practices include questionnaires, audits, and the implementation of staff education or visual aids for inpatient settings. Coming back to the primary scenarios as stated in this presentation, we have made suggested changes for improvement. In the case of a nurse neglecting to clean their stethoscope in between patient interactions, the group is recommending the RN make use of facility-approved wipes or sanitizer to clean equipment before seeing the next patient. Secondly, in the case of noncompliance with droplet precautions, it is suggested that the RN and student ensure patient masking for PPE adherence. Finally, in the case of a PCT neglecting to perform hand hygiene before entering a patient room, we are suggesting that hand hygiene education be taught to promote infection control before and after each patient encounter. Due to isolation precaution compliancy issues, it is our hope that patient outcomes will benefit with infection control as a direct result of the proposed Lewin change model theory. To summarize the previous slides, our group is unfreezing the issue of PPE noncompliance by recognizing a need for further education and assessing knowledge of current PPE understanding. This step of the model is expected to be completed within 1 month time. Secondly, the group will be implementing new education and reinforcement of appropriate PPE compliance as part of the change step in Lewin's change model. This will be completed by statistical analysis, surveys, and audits with the aid of demonstrations and seminars for staff members. This step of the model is expected to take 1 to 3 months to complete. Finally, we are refreezing or monitoring the effect of our change by reassessing nursing knowledge and demonstration of proper PPE use in the hospital setting. This stage is the longest of Lewin's change theory and is expected to take roughly 6 months to complete. If successful, implementation of evidence-based practices and standards will be able to improve PPE adherence and thus positively impact patient outcomes. Thank you all for listening to our Change Project. Here are the references we used for this presentation. Finally, here is a statement of authorship to whom it may concern. Thank you.